Hello, everyone, and a very warm welcome to the last live session of COVID-19 conference, proudly presented by the International AIDS Society. My name is Linda-gail Becker, and I come from the Desmond Tutu HIV Centre based in Cape Town. And this session is entitled Country Policies and Practices, Different Pathways and Similar Intentions. Countries around the world have responded to the challenges of COVID-19 by developing and implementing a range of policy responses to ensure that the virus is contained and its effects across society mitigated. I think we've heard already some fascinating data and some sobering and disturbing facts of what some of the implications of this might be. At this stage of the pandemic, it may be too early to attribute success in a response to any one policy measure. This session, with speakers who are leading the policy response across different contexts and in different countries, will aim to discuss considerations, decisions taken, and timing of policies enforced during the responses to COVID-19. And we will together reflect on the relative challenges and successes of those actions. So today, the format of our session is that we will have a plenary speaker with Professor Peter Piot from the London School of Hygiene and Tropical Medicine. And then we have three invited speakers, Dr. Erica Lee from the Career Centers for Disease Control and Prevention, Dr. Kate Hankins from the McGill University and COVID-19 Immunity Task Force for Canada. And finally, Dr. Srinath Reddy from the Public Health Foundation of India. We will follow this with a question and answer session where we invite you all to send us your questions. We're waiting to hear from you. And the idea is that we then reflect on those questions and pose that to the panel. So please send your questions to coronaquestions@iassociety.org and on Twitter with the hashtag, as you can see on the screen. We will try to answer as many questions as possible once all of the panelists have presented. So it's my great pleasure now, without any more hesitation, to introduce to you Professor Peter Piot. He will be our plenary speaker and will present on the topic, Living with COVID-19, Lessons from Other Epidemics. Professor Peter Piot is the director of the London School of Hygiene and Tropical Medicine and the Hander Professor of Global Health. He was the founding executive director of UNAIDS and Undersecretary General of the United Nations from 1995 to 2008. He's a clinician and microbiologist by training, and importantly discovered the Ebola virus in Zaire in 1976, subsequently pioneering research on HIV, women's health, and infectious diseases in Africa. He's held academic positions at the Institute of Tropical Medicine, Antwerp, the University of Nairobi, and the University of Washington, Seattle, Imperial College London, and Collège de France, Paris, and was a senior fellow at the Bill and Melinda Gates Foundation. He's a member of the US National Academy of Medicine, the National Academy of Medicine of France, and the Royal Academy of Medicine of his native Belgium. He's a fellow of the UK Academy of Medical Sciences and the Royal College of Physicians. He's published over 580 scientific articles and 16 books, and I highly recommend to you his memoir, No Time to Lose. Peter, we're really looking forward to hearing from you. Over to Professor Peter Piot.
Thank you very much, Linda, and thank you to IAS for bringing together the two biggest epidemics of our time. I mean, HIV/AIDS and now, of course, COVID-19. I should correct one thing, that is that what you said, I'm one of a whole group of people who discovered the Ebola virus. It was not just me, I was only 27. But it's really important that we, as many speakers have said, we realize that we're at the beginning, only at the beginning of this pandemic. And so unfortunately, COVID-19 is not going to go away one day, soon, and even probably not in the medium term. And it probably will progress through several waves and flare-ups across the world and within countries. And whereas we badly need a vaccine, and we've heard about that, we must also be realistic what it will do in terms of timing. When will it be available? Who will have access to it? Will people accept it? And what will be the impact? What will be the type of protection? And I'm mentioning that because it means that what particularly some scientists and some politicians are saying, okay, let's keep a hold and and continue to do what we do now. It's very tough, but one fine day the vaccine is there, and then we can go back to normal. Forget that. That's not going to happen. So we need to shift our thinking to see ourselves as living, as operating in societies living with this virus, and living with SARS-CoV-2, just as we are now in societies living with HIV. And it's we've got people living with HIV, we've got people living or surviving of COVID-19. But it's as societies that we have to start thinking, even if we're still in the middle of an acute epidemic in many, many countries. So we need to think not only in terms of how to deal with the acute crisis, because it's still there, even in countries that have been relatively successful in bringing down new infections, but also take a long-term view and think how to deal with a pandemic, during several years. That's sobering, and I'm not a doom thinker or a pessimist, but I think we have to face this reality. And this means many, many things, but just two. One is that the uncertainty about the future, about what to do exactly, is going to continue, and which kind of tools will come up. Although I feel that we know enough to bring down new infections. I mean, the good news is that quite a few countries have been successful in at least temporarily bring down new infections. So we need to, to learn while we're sailing, or I would say while we're racing, because it's more of a race. And secondly, second consequence about the fact that we're, in here for the long haul, is that it is extremely important and relevant to constantly learn as we're confronting these outbreaks. It's not too late, and this is not an academic exercise, and it's not about the past and blaming and so on, and that is a waste of time. I think it is about the future. What can we learn? Because we will be confronted with it. Now, one of the mistakes that I made, and many of us wrongly assumed, was that SARS-CoV-2 would behave like influenza or like SARS. I mean, these were the models we were familiar with, although very, very quickly it appears that this is unlike anything else. It is, COVID-19. There's nothing like it at the moment, and that we've seen. And yet, even if it's unique, we've learned a lot from other fights against other epidemics, from influenza to HIV, even Ebola in some countries. And that is going to be one of my main themes, the lessons learned for that, combined with lessons learned from the initial response. Because it's initial. I mean, it's 6 months at the most in countries. In some countries, it's only a couple of months. And 10 brief points. The first one, we know all that is act early. Linda, this is a commercial now. Linda-gail mentioned, no time to lose. That's why the title of my book is No Time to Lose, because anything that is contagious, if you can nip it in the bud in the beginning, you're not only preventing the next generation, but many, many generations to come. So you can save literally millions of lives by preventing a few cases at a very early stage. And here, that's the societal difficulty, is that acting before you have a big problem is extremely difficult. Is extremely, I mean, theoretically, that's kind of straightforward. In practice, particularly when it's, we're confronted with an epidemic like, like COVID-19 or even Ebola in West Africa, where pretty draconian measures are necessary in the beginning, that's hard for society to accept. But that's act early. However, this is not only important at the very beginning, and it's too late for that in many countries. When I look at the UK, we were far too late. We were consistently a few weeks later than was necessary for everything. Even the debate about face masks is still going on. It's hard to understand, but anyway. So that is going to cost lives. But it's also acting early when the flare-ups come. We've seen countries that were among the leaders in this response, like in Europe, certainly Germany. We have Singapore, South Korea, for example, where after initial success, in each case, in a very different environment, we saw outbreaks. So acting early there, no time to lose. Secondly, as we also know, and as we've learned from AIDS, and I think that's good news, HIV has shown us that nothing short of amazing progress is possible in terms of behavior change. It is possible against all odds. And this is about sexual behavior change, which is probably the most difficult of all, but also how difficult it is to sustain it. And that is what we are now also being confronted with the response to COVID-19, where, we are seeing a backlash where there's angriness and some anger about what's happening. And so that's again where political leadership is really key, but also take into account an enabling environment. It's behavior change and behavior and operates in an environment that has to, where we have to take into account people's needs and choices and vulnerabilities. Thirdly, no magic bullet. Forget about that. Again, a lesson from HIV, and that's very applicable here, is that what we need is a combination prevention. Many societies have gone through a really bulldozer approach because we're acting late, with total societal lockdown. That is not sustainable for many, many reasons that have been addressed here. But even if when we'll have a vaccine, and I hope we will have one, we will need to continue certain measures, and it'll be a combination of, personal behavior, national policies, and technology, I hope. Fourth point is, and this sounds like a broken record, but is the leadership at all levels. It's not just political leadership. That's key, of course, and we see the devastating impact of the lack of the negative political leadership from Thabo and Becky when we're dealing with HIV to Bolsonaro or Trump. These are things that have really an impact on people's lives. It's also the positive leadership, of course, but it's also this operational leadership, there is scientific leadership, and all that is needed to not only sustain a sense of urgency, but it's also to make sure the resources are there. And again, from other epidemics, we know that how much of a difference that can make. Fifth point is that, and I think here we are in a good space, is to embrace science and technology and innovation. After many problems, it's to say so, like with the HIV epidemic, where the science was also extremely unclear. There was no treatment. We still do not have a vaccine, but it's a completely different type of infection because there's no natural clearing of the virus in HIV infection. So a vaccine is far more difficult. Whereas in COVID-19, there is clearance of it, but it is the fact that we now have for example, in the UK, after a period of lack of trust in experts and in science, science advice is back on the agenda in many countries. to advise those in power of what works and what doesn't work. The problem is, of course, that scientists, in a sense, we love uncertainty because that is our, the reason of doing the research. And so we need to be very careful the kind of relationship between scientists and decision makers, where it's clear that we each have to be clear what our roles are. I mean, scientists are advising here, and politicians or those in power have to decide. And that's a delicate tension that we're trying to operate in. It also brings together, at the forefront, scientific debate. When scientific debate that we're used to as scientists, when that's happening in the open, that undermines then in the eyes of the public the credibility of science. And yet for science, it's essential to have that debate. Very, very difficult in these times. But I think the role of scientists is also to speak truth to power when we believe that things are not going into the right direction, or that wrong decisions have been made. And of course, we heard about the vaccine development and so on, and that's good news. Also, the fantastic flurry of innovation, of even international cooperation. One of the most frustrating aspects that I found in the Ebola West Africa outbreak was the lack of sharing of data and of sequences, the virus, and so on and so on. Here we are in a much, much better space. Actually, the daily problem is how to keep rest of all the information. It's an avalanche, a tsunami of information that personally I have problems following on. Now, the sixth point is that I would say context and local action. It's also great to have national policies or global policies and so on, but at the end of the day, what will matter for people's lives is action where they, in their community, local action. I think is another very important lesson from HIV. It means that we need granular information, national, prevalence incidence data, or what made it to the forefront with the prime ministers giving lectures about the reproductive rate and the meaning of R0 and so on. Frankly, that is pretty meaningless at a national level. What matters is, in your community or subnational level. And so that means that we need far more granular information that is immediately in real time available for local decision. And we need also far more tailored responses that are grounded in the realities of not only the epidemiological ones, but the cultural and economic, etc. realities. So it's really, we talk a lot about precision medicine, but this will require precision public health action, which will become far more important now that we are going through a next step of outbreaks. And that means also trust, community trust and confidence at the local level. If that's not there, we're not going to be able to do it. And we saw already the problems of it, demonstrations, even violence, when a second wave is there with or outbreaks. And that means also taking into account those who are the most vulnerable, because this epidemic, like many others, have revealed and deepened the fault lines in society, and those are the most vulnerable, are the ones who are most hit. Eighth point, and I'm nearly finished here, and that is that human rights and needs of survivors must not be ignored and must be involved. Now that I'm myself an experienced expert, since I went through COVID-19, of course, I feel that there is something to contribute. And for example, we will see hundreds of thousands, if not millions of people with chronic conditions, chronic sequelae from this epidemic. It's not just an acute issue. And we need to take that into account, but it's also a matter of, the thinking of human rights in terms of the policies that are being made. Ninth point is, I mentioned before, plan for the future. It sounds a bit difficult, but we need to plan for the next epidemic now. This is the time to make sure that we don't commit the same mistakes and not investing in epidemic preparedness. Although when you look at international rankings of countries in terms of epidemic preparedness, those who were at the top have done the worst, US, UK, and so these are box-ticking bureaucratic exercises, nothing to do with reality. And finally, activism. This is what we will need, again, for a long-term response. Particularly, this is affecting the lives of young people. Older people are the most vulnerable and die from it. But in terms of the consequences, the impact is young people. Okay, so let's not forget that COVID is unprecedented, uncertainty, early days, we will have to learn. But what the future will bring will really depend on, I would say, whether we're successful, depend on the interaction between local empowerment and action, national and global leadership, and then the impact and access to technology. If one is missing, I think we will fail and we're in deep trouble. Thank you.
Peter, thank you so much. I've always thought of you as the virus slayer, and I know you've been public about your own personal encounter with this particular virus. And I just want to say from the world at large, we are very grateful and relieved that you've come through it, you're on the mend, and we really want to appreciate those reflections, which I think really resonate with where we need to be now as we move forward into, as you say, a sustained response to COVID-19. Please stay on the line. We will invite you to join us on the panel in a moment. So now it's my pleasure to introduce to you Dr. Erica Lee, who will present on the following topic: preparedness and response to COVID-19 in the Republic of Korea. Dr. Erica Lee has held a number of senior roles at the Ministry of Health and Welfare in Korea, including serving as the director of the Jeju National Quarantine Station and deputy director of the Division of Plan and Coordination prior to her current role as director with the Korea Centers for Disease Control and Prevention. She holds a PhD and a master's in public health, along with the BSc in microbiology and immunology. During her academic career, Dr. Lee conducted research and projects on public health law and ethics. After the 215 MERS outbreak, she was involved in reforming and reconstructing the public health emergency preparedness and response system at the Korea Centers for Disease Control and Prevention. It's my pleasure now to hand over to Dr. Lee. Thank you.
Thank you. Greetings from Korea. It's my great honor to share our experience and the lessons learned on responding to COVID-19 in the Republic of Korea. Next. In Korea, the peak of the transmission so far was on February 29th, with a record of 909 confirmed cases in a single day. After that, newly added cases have slowly decreased. Since March 12th, the number of daily confirmed cases decreased under 10 until early May, actually. However, after relaxing to a new routine distancing in daily life, the number of cases has been increased due to the cluster transmission continuously occurring in the Seoul metropolitan region and other metropolitan regions as well. Since May 6th, the number of confirmed cases have been increased and more local infections are reported. But this week, the trend has become changed. Recently, the number of daily new imported cases is likely to exceed the number of local cases. Previously, most imported cases were from Europe and Americas, but recently, the imported cases are mainly from Asia, America, Europe, and Africa as well. For last 2 weeks, 45% of new cases are local clusters, and the 36% is imported cases. And just 1.4% of cases has occurred at hospitals, nursing homes, and etc. Actually, based on the lessons learned from MERS, KCDC has gone through the reform in its organizational structure and system. We have introduced and established the new infrastructure and the systems while expanding and reconstructing our existing health system and public health personnel. Actually, this was from the recommendation from WHO ROK Joint Mission on MERS outbreak in 2015. After this mission, the important recommendations have made. Early identification and monitoring of all contacts was the first recommendation. Second, regular provision of information to the public, including prompt information sharing. And the third, strengthening capacity of medical facilities, including training experts for infection control and prevention, as well as laboratory. Actually, these are the measures that we have taken different from 2015 MERS outbreak for COVID-19 response. We have concentrated on risk assessment and risk communication domestically as well as internationally, and we have strengthened the full engagement of local and multi-sectoral collaboration. Most of all, early detection through rapid testing and active case finding, as well as contact tracing, have been the key approach in Korea. This slide shows the timeline, the progress of the situation, and how our government responded to COVID-19. After the cluster cases of unknown pneumonia originated in Wuhan were first reported, we issued alert level 1 right away and began to prepare for possible importation of COVID-19. The alert level increased to level 2 when the first case was confirmed in Korea, and then to level 3 after more imported cases were confirmed. Actually, secondary transmission were reported after that. Finally, the alert level was raised to level 4, which is the highest level in response to the big clusters in late February. Again, after 2015 MERS, KCDC established the national laboratory system. We are operating tiered laboratory network from the national to the local level that is evenly distributed throughout the country. We also established a specimen transport arrangement within 24 hours for confirmatory testing even before COVID-19. Finally, we have established also the emergency use authorization EUA system, which permits temporary use of unapproved in vitro diagnostic devices during infectious disease outbreak. For COVID-19, we use this system for RT-PCR testing kit. In the beginning of the outbreak, only KCDC was available for lab testing. But later on, it is expanded very quickly to the research institutes of public health environment, which is affiliated with local governments and private medical laboratories and hospitals as well till very early February. Therefore, currently, we have a total of 127 testing institutions available, and the average testing capacity for now is 20,000 per day, and maximum is 30,000 tests per day. These are the pictures of drive-through sample collection and screening centers, which has contributed to rapid testing because we had a very quick sample collection. We could also shorten the testing time. We also introduced the walk-through system and also other types of this sample collection system. Next one is about the contact tracing strategy. There are mainly 4 steps: investigation, risk assessment, contact classification, and context management. At the investigation level, we obtain preliminary information through interviewing the patient, primary physician, and family to compensate missing information or confirm the interview outcomes. And then we collect additional information at the stage of risk assessment of the case. Information such as medical records, mobile phone location using GPS, card transaction log, and video footage are collected and investigated in this stage. Based on this information, we classify the close and casual contacts and provide guidelines from movement restriction to symptom monitoring. This is the timeline shows the various response measures Korea took along with the progress of the outbreak, especially during the first wave. We tried to consider and conduct appropriate and effective measures for each phase of the outbreak. In response to the increase in case fatality rate during this first wave, as a mitigation strategy, we established a new system to focus on more healthcare resources on severe cases. First, we categorized confirmed cases into 4 categories: mild, moderate, severe, and very severe. Each category receives different treatment and gets admitted to different types of facilities accordingly. This was very important in ensuring sustainability of our healthcare system in Daegu and Gyeongbuk areas where we had big clusters. This slide is about the living and treatment support centers for mild cases. If these mild cases develop severe symptoms, then they would be transferred to hospitals for further treatment. Next one is about the use of our ICT into the response measures. We also further adapted the information technology for efficient and creative measures, such as the self-health check mobile app, as well as self-quarantine safety and protection app. The last the measure that I would like to really emphasize is the social distancing measures and the importance of risk communication. After the peak of the transmission on February 29th, we started recommending the public to practice social distancing. Public compliance to this social distancing campaign was generally very high in Korea. On May 6th, we transitioned to a new campaign called a new routine distancing in daily life to advise the public to continue to practice social distancing while pursuing their daily life activities. This is very difficult, but our public actually followed these guidelines, I think, relatively very well. We still need to learn more about COVID-19. Till now, we have known that COVID-19 is highly infectious, very much transmissible, and it's very infectious from early stage, and it spreads rapidly with cold-like symptoms, or sometimes it's asymptomatic. New technology is also required to ensure enhance our traditional control and response measures, as well as develop novel measures. Sharing the knowledge and practices each other would be the key to overcome the current global pandemic. Thank you very much.
Thank you very much, Dr. Lee. And I think Korea remains one of those countries that I think we've followed with great interest, and we appreciate that very clear description of your response. Please stay on the line for our panel. Our next speaker really needs not only a warm welcome, but also congratulations. It's about 3:30 a.m. in Canada, where Dr. Kate Hankins is at the moment. So Kate, first off, we just want to say huge thanks for being up so early or being up so late. I'm not sure whether it's your Friday or your Saturday morning at this stage, but we're thrilled to have you, Kate. Dr. Kate Hankins co-chairs Canada's COVID-19 Immunity Task Force. She's Professor of Public and Population Health at McGill University in Canada and is Deputy Director of Science at the Amsterdam Institute for Global Health and Development in the Netherlands. Dr. Hankins is Honorary Professor at the London School of Hygiene and Tropical Medicine in England, and she led the development of good participatory practice guidelines, very important guidelines, for trials of emerging pathogens for the WHO. She chairs the Scientific Advisory Committee of the European and Developing Countries Clinical Trial Partnership and the Scientific Advisory Group of the US National Institutes of Health HIV Prevention Trials Network. She's a trustee of the HIV Research Trust and a member of the International AIDS Society Industry Liaison Forum. Importantly, and I think deservedly, she was named to the Order of Canada in 2013. Kate will be presenting to us today, Canada, Beyond the SARS Playbook. Over to you.
Thank you, Linda-gail, and thank you so much to the organizers for inviting me to speak about Canada's response. I'm just checking to see if I can advance my slides. Yes, I think so. So I'm going to talk about Beyond the SARS Playbook, what happened in Canada. Sorry, this is moving too fast now. And how that playbook was put into action. We'll look at the cases by province and territory and then see how SARS-CoV-2 has followed the fault lines in Canadian society. We'll look at deaths and we'll see what happened in long-term care in Canada, and then think a bit about how to update the pandemic playbook. So Canada pulled out the SARS playbook. We had SARS in 2003, 438 cases and 444 deaths in Canada. And it was a wake-up call. It revealed systemic flaws in Canada's healthcare system. And it led to the creation of the Public Health Agency of Canada, appointment of a chief public health officer, development of guidance to prepare for and respond to a pandemic, enhancement of diagnostic capacity at our national laboratory, and strengthening of working relationships with WHO, CDC, and other international partners. If we look at what happened rolling out that playbook, after China confirmed the first case on January 7th, the Public Health Agency of Canada activated the Emergency Operations Center and triggered the Public Health Response Plan. COVID screening of travelers returning from China began January 22nd, and on the 25th, our first case of COVID-19 was confirmed, and it was related to travel to Wuhan, China. January 30th, WHO declared the COVID-19 outbreak a public health event of international concern, and Canada established a special advisory committee on novel coronavirus, and the Prime Minister convened an incident response group on coronavirus. He then went on to create a cabinet committee on the federal response to COVID, chaired by the Deputy Prime Minister and vice chaired by the Treasury Board President, indicating that we knew there would be major economic input or effects. The first death occurred March 9th, and shortly thereafter, WHO declared the global outbreak a pandemic. Canadians were advised to avoid all non-essential travel outside of Canada, and travelers entering Canada were advised to self-isolate for 14 days. There was a ban on foreign nationals from all countries except the US from entering Canada. The Canada-US border, however, was closed to all non-essential travel, and it remains closed. International passenger flight arrivals were redirected to 4 major airports. And despite this, Canada went from 10,000 confirmed cases to 50,000 within 1 month. This is what happened by province and territory. And it's quite striking to look at the fact that 95% of the cases occurred in 3 provinces. In Quebec, the darkest blue, Ontario next door, and Alberta in the west. Over 3 million people have been tested. It's a rate of about 82,000 per million, and 3.2% of those tests have been SARS-CoV-2 positive. I'll just point out that 56% of our cases have been female. Following along the fault lines, these are some of the things that really made a difference in Canada. First of all, believe it or not, fax machines are used to communicate critical epidemic data, and the data are incomplete and they're not timely. Secondly, diagnostic testing focused basically on travelers until late March, ignoring the likelihood of community transmission, and until very recently, ignoring asymptomatic transmission. In Montreal, people in poorer neighborhoods were 2.5 times more likely to be infected than those in the wealthiest. And that was due to higher concentrations of essential workers, including factory workers, dense populations and more crowded housing conditions, and higher rates of pre-existing health conditions. Drug overdoses in Vancouver soared, and deaths due to injecting or smoking fentanyl increased beyond the COVID-19 deaths because the borders had been closed and trade was restricted, and this led to toxic local drugs, as well as people consuming on their own because there were no, for a month, the supervised injecting facility was closed. Women were disproportionately affected, and I think we see this around the world. They experienced more job loss, increased childcare responsibilities, decreased productivity, and it's having a major impact on their career advancement. There was spread into communities from long-term care residents and care workers. And if we look at the deaths that have occurred across Canada, 81% were in long-term care. This is a devastating finding. This compares to 28% in Australia, 31% in the US, and 66% in Spain. What was happening in long-term care? First of all, there were a number of failures. There was a failure to address the fact that longevity is increasing with chronic diseases and dementia, raising the need for complexity of care. There was a lack of universal standards, defunding, privatization, dysregulation, and a major workforce crisis. Unlicensed care aides and personal support workers are paid the lowest wages in the healthcare sector, and half of them have no paid sick leave. They have part-time work, which led to multi-facility work, which facilitated viral spread across institutions. Families and friends were unable to access the facilities to provide care for loved ones. The result was elderly people dying without family, anxious, afraid, surrounded by people in frightening protective equipment. So many care workers were sick in Quebec that over 1,400 armed forces personnel had to be deployed to long-term care homes. Canada gets good marks for a number of things. The physical distancing measures and the social isolation was good. There's been unprecedented economic support for citizens, small businesses, and sector support. Investments in research and treatment trials, vaccine research, and the COVID-19 Immunity Task Force. But Canada was slow on borders, slow on testing, and slow on masks. Significant investments are needed to address, among others, the surveillance system, which I had pointed out, the need for regulation of care provision in long-term care, underlying social determinants of disease, including housing and pre-existing morbidities, how our cities are designed, and whether the time for a basic universal income and a universal childcare plan has arrived. And all this has to be done without distracting from the biggest global crisis we have, the climate crisis. And I think a number of speakers referred to that yesterday. So basically, sober examination is needed now of the lessons learned. What is the optimal division of powers and responsibilities between the federal, provincial, and territorial governments? What worked best in which settings and why? And what do we have to do to update the playbook for the second and third wave and for the next pandemic? Thank you very much for your attention.
Dr. Hankins, thank you. That was just a fantastic, I think, and succinct score chart, as you say, of Canada's response. And thank you for the introspection. I think really helpful for us to hear how you in the North are thinking about your success to date. Kate, stay on the line. And I would also remind all listeners, please to send your questions in. We're wanting to hear from you, and we want this to be as interactive as possible. So do post your questions. Our final speaker in the lineup this morning comes to us from India, Dr. Srinath Reddy. Welcome to you and thank you for being on the line. His talk will be on India presents many faces of the epidemic. And I'm happy to introduce Srinath Reddy as the president of the Public Health Foundation of India and formerly head of the Department of Cardiology in All India Institute of Medical Sciences. Under his leadership, PHFI has established 5 Indian institutes of public health in different regions of India to advance multidisciplinary public health education, research, technology, and implementation support for strengthening health systems. He was appointed as the first Bernard Lown Visiting Professor of Cardiovascular Health at the Harvard School of Public Health in 2009, and presently serves as an adjunct professor of epidemiology at Harvard currently. He's also an adjunct professor of the Rowland School of Public Health, Emory University, and honorary professor of medicine at the University of Sydney. Professor Reddy is a member of the Government of India Technical Task Force for COVID-19 and an advisor to the governments of Odisha, Punjab, and Andhra Pradesh on public health. Over to you, Dr. Reddy.
Thank you very much. Greetings of the day to all those who are attending this webinar, whichever time zone they are in. As far as India is concerned, COVID-19 entered as the virus in an infected person on the 30th of January through a student from Wuhan, an Indian student who returned along with other Indian students studying in China. Since then, India has had periodic upswings of the epidemic with a huge scale up of the number of cases and a lower level of scale up of deaths in June after the lockdown period finally ended. Right now, we are in the unenviable position of being listed in the top 3 countries in terms of the caseload of about 821,000 cases. And we have about 22,000 deaths attributable to COVID-19. However, if you do take India's large population size into account, our cases per million are about 612, and our deaths per million are about 16.5. Even assuming that there is underdiagnosis because of limited testing in the initial stages, as well as undercounting of some of the deaths, still for a population of this size, the infectivity rate and certainly the death rate is rather low. That is attributable mainly to the younger age, but also substantially to the large rural segment of the population where the mobility of people as well as the virus is much less. As of now, out of 739 districts of India, 49 districts, that is about 6.6%, account for 80% of the cases. 8 large cities and the surrounding districts are those which are most infected. Whereas large parts of India, the smaller towns, rural India, and good part of eastern India are not affected. Therefore, the epidemic assumes not one single curve of the epidemic progression of rise and fall, but of multiple different infectivity periods. And therefore, we are likely to see this calendar evolving differently in different parts of India. We do have, however, despite the younger age profile, which is a distinct advantage, a large number of comorbidities. We find diabetes and hypertension are particularly prevalent along with premature coronary heart disease, not only in urban areas, but now also in rural areas. For example, in Delhi, in the 40 to 49-year age group, there is a 40% prevalence of hypertension. And in the 20-plus year age group in Delhi, we have a 25% prevalence of diabetes and pre-diabetes to the extent of 48% more. Therefore, we do recognize that there is a risk even in the middle age and not only in the elderly. And this has been borne out by the death profile, where about 32% of the deaths attributable to COVID-19 have occurred in the 45 to 59-year range across the Indian population. And in terms of the 60 to 74-year-old population, it's about 39% of the deaths. Therefore, we do need to be cautious about both the spread of the virus to hitherto less affected areas, particularly the rural areas and much of eastern India, while we are battling to put down the fires in the large cities and the surrounding districts. And therefore, we have seen a varied response building up from the initial stages. Apart from having relatively low access to testing kits, as well as personal protection equipment, and even limited number of government laboratories in the early stages of the epidemic, a good deal of capacity has been built up, both for production and procurement of testing kits, as well as personal protection equipment, and more laboratories, starting with government laboratories and the research laboratories, and now the private laboratories performing these tests. The tests have also extended from the classical RT-PCR to recent deployment of antigen testing kits, which permit faster on-the-spot testing, but with a lower degree of sensitivity and therefore greater chance of false negatives. With the
Linda, can you take over? We lost Dr. Reddy, unfortunately.
Thank you. It seems that we've just lost Dr. Reddy. I'm going to suggest, whilst we wait for his reconnection, that we start our panel discussion, and maybe we can give Dr. Reddy an opportunity to finish, I think, what we want to hear from Dia.
I think I'm back in action now.
Terrific. Dr. Reddy, over to you. These are the hardships of live streaming from across the world, but we appreciate your resilience as we carry on. So please, over to you.
So we had gone into a nationwide lockdown on the 25th of March, and the lockdown was in 4 phases. First 2 phases were fairly strict and nationally applicable up to the 3rd of May. Subsequently, there were a number of relaxations permitted with regional variations. And now we are finding again the different states which have now taken up the main decision-making role from the central government are now either permitting a large number of activities or going into restricted local lockdowns. But there has been no resistance to the use of masks or face coverings, culturally or otherwise. That has been generally adopted universally and mandated as well. And physical distancing is followed to the extent possible, given the crowded circumstances in some of our cities. But even in the largest slum of Asia, Dharavi, where much was feared in Mumbai of a huge upswing of the epidemic, there's been a remarkable level of control, even mentioned positively by the Director General of WHO yesterday, because with the cooperation of the people concerned, the slum dwellers, as well as effective public health methods, the epidemic was very effectively controlled even in this crowded, difficult slum area, which is an example for other slums in the country. Of course, we have had progressive opening up, but even now malls, movie theaters, schools and colleges are closed. But there are some gatherings that are permitted in terms of religious gatherings and some political gatherings as well, which could be possibly done without, but nevertheless, it's happening. But one of the lessons that has come up and which is very definitely applicable from the learnings of HIV is that we definitely needed a huge amount of community engagement. And primary healthcare was particularly critical, whether it is syndromic surveillance on a household basis with primary healthcare teams, most often were partnered with citizen volunteers in the southern states of India, exemplified by Kerala, but also in terms of destigmatization, because stigma and fear certainly dominated quite a lot because of the fear of the epidemic, because of the kind of messaging that was going on media channels. Here, the community engagement was very critical. So the states which actually had a good community engagement did much better, both in terms of public health measures and in terms of destigmatization, and even in contact tracing. So that is one lesson that we must really carry forth as we plan for the future epidemics. Therefore, I would say what we require is a new type of PPP, not a public-private partnership, but people-partnered public health. And that is something that has been demonstrated in some of these states. At the same time, as we move forward, we need to look at how we can actually respond to this epidemic in the public space with care, caution, and confidence. Care at the personal level with masks and hand hygiene and physical distancing to the extent possible, but caution also in avoiding crowded places, particularly indoor crowds, because of the new risk that has been recognized of aerosol spread. But also move with confidence to resume some of our activities and destigmatize so that people can actually respond with a greater degree of social solidarity, both at the local community level and the national level, and with global solidarity at the global level. I would entirely agree with the 10 points that have been mentioned by Professor Piot, but I would like to extend one more. We cannot really deal with these epidemics without looking at the ecological despoilation that is responsible for the huge flurry of zoonotic outbreaks and pandemics that have been recurring over the last half century. The more we deforest, and the more, because of our urbanization in terms of our mining activities, as well as also for agricultural activities and livestock breeding, the more we are creating conveyor belts for hitherto confined viruses and vectors to travel from forest animals where they're relatively quiescent to enter captive veterinary population and human habitat and become much more virulent. And that is where, and much more mobile. And that is where I believe, while we need to build up a very strong health systems and also enable a good deal of citizen participation, we also need to look at how we can actually retain or regain some ecological sanity so that we put the brakes on zoonotic pandemics. And that is where I believe the scientific community involved in HIV/AIDS or in COVID-19 must join hands with other sectors in order to develop a new development paradigm for the whole of the global community. This is a global threat that requires a global trust to counter it, and therefore the need for global solidarity, not just whenever a pandemic occurs, but in order to rebuild our plan for ecologically sustainable and equitable global development. Thank you.
Thank you, Dr. Reddy. And I'm going to, I think that 11th point is absolutely salient. And I hope everyone had a chance to listen to a previous group of talks where that was really highlighted. We're now going to bring all of our panelists back into sharp view so that we can have a bit of a discussion, and we'll be doing this until 10:30 or so. I want to remind you all that you can send your questions to coronaquestions@iassociety.org or via Twitter using the hashtag COVIDquestion. And I'm going to pick up on the first questions. First question, Dr. Lee, to you. Dr. Hankins mentioned what they could have done better. I'm wondering if you could, I think Korea had a fantastic fast response. If you, with the value of hindsight, what is one thing that you would have done better in terms of the Korean response to COVID?
Actually, we've learned from MERS outbreak, and then we had an experience, but our MERS outbreak experience was mainly limited to the hospital-acquired infection, because most clusters were related to hospital infection in MERS outbreak. So we haven't actually prepared for the widespread at the community in the early stage. So during our first wave, our government was really having some kind of tough time to prepare for these healthcare resources to those high number of the patients in the short times. Actually, we managed to do that, but we still needed to prepare for the second wave coming for those kinds of healthcare resources for like a big clusters and then or big numbers that might be coming next stage. So that might be the one that we could have done better if we were prepared at that time.
Thank you for that. And I'm going to ask Peter to pick up on one of the points, which and I think was a point really labored by everyone, that we now need to move into the sustainable sort of forward-looking model. So how do we actually do that behavior change? You mentioned you think it's possible, and we've shown in HIV we can. The big question is, how do you sustain it? But how do we actually move into what Dr. Karim yesterday, described as the self-efficacious, the community, the citizen response? What are some of the pointers you think we could discuss now?
Thanks, Linda-gail. First, let's start with some institutional issues, and I think Kate Hankins really alluded to that. How and also Dr. Lee, how some of the lessons of SARS or MERS were applied and were implemented. The problem is that once an epidemic is over, it's no longer headline news, we tend to forget. But at least in some countries, there is some institutional arrangements being put in place. I was surprised to see that in Canada, it took SARS to establish a public health agency and so on. So, and we've seen the same thing in 100 years ago after the Spanish flu, where in several countries, this kind of public health institutions were established. So that's let's say the institutional aspect, and both Dr. Lee and Dr. Hankins have been really giving a list of that, also Dr. Reddy. And I think that we should not underestimate that, because without some kind of infrastructure, without also a culture institutionally of dealing with this and preparedness, we're always start from scratch. And that's how it felt in most of European countries. And that went from really basic things like no stocks of PPE, of protective material, to not having an infrastructure for contact tracing. Use of the fax machine is kind of hilarious, but that's it is part of that reality. So that's one thing. But secondly, I would say there's what I would call culture. Culture is really important here. And one of the things that strike me, first time I went to Japan in my life was in 1980 or 81. And I saw people walking in the street with face masks. And I thought, these people are paranoid. They're so scared of becoming infected, until someone told me, no, it's to protect the community. And that started also historically after or during the Spanish flu, so 100 years ago. So that led to a profound behavioral change. And I think the time, I come from a culture where shaking hands is really all the time. You do it and you hug people and so on. It's not like Brazil, where meeting someone is total body search, and then in other societies you don't touch. But I think that the time of handshaking is probably gone forever, in terms of you know. So there is a need for cultural changes. And then there is, thirdly, is a community, what is acceptable. A few things here I would say. One is that we've seen that with some other epidemics also, that communities and people have not waited for the experts and for listen, they organize themselves. And here, because it's about survival. And but we've not been really involving them. And it's interesting what Dr. Lee said, indeed, also in the UK, one of the strengths of the National Health Service is primary care, the GPs. They've been completely excluded from the response. It's all been hospital-based, and you know, and that I think is has been one of the fundamental flaws, to exclude this community part, those who are closest. And I think then we should also look at education and you know, just having a more of a risk management and what I would call harm reduction. In the so our starting point is we have to live with this and how to make it safe, and that in each community we have to do, but we have to really start that conversation, and in a very honest way. And what Slim said, indeed, I totally agree that that's the way to Slim Abdul Karim to go, because otherwise it's not going to be sustainable. We see already in many societies, particularly when there is a second, a need for a second type of lockdown or draconian measures, people are angry. And you know, and this is going to create a lot of social unrest, also because it has pushed people into poverty and loneliness. You know, gender-based violence is on the rise, etc., etc. So, so we will not be, you know, this cannot be sustainable without addressing all these issues. We can go into, but that in itself, I think, is really important to address now and not wait until it's flying flat in our face. Over.
Thanks, Peter. Yeah, you raised some really important points there. I want to just say, I loved on your slide, Dr. Lee, that we can still hug our family members, and maybe that's the out for the future, that we still get that human contact from people within our own household. So important. But Kate, turning to you, I think you highlighted, and I think starkly, how the vulnerable have somehow fallen through the cracks and maybe through those fault lines, and particularly the elderly, as you pointed out there. So I do want to reflect a little bit more about doing everything for everyone, or as Peter, as you suggest, the sort of harm reduction approach. Do you want to elaborate a little bit, Kate, about what Canada's done around school going and return to school? Because that's also been very controversial, obviously, and somehow I feel for different reasons, children around the world have fallen through the fault lines, as it were. So just some thoughts about school going.
Yes, so just as with health, education is also a provincial responsibility. So the policies are made at the level of each province. And within provinces, there are areas that have been harder hit. And so they have different policies. Everything is being staged. For example, in Quebec, which was very hard hit, schools opened, but they open with, it's voluntary, and their parents that are really deliberating about whether to send their kids back, partly on the one hand, because they may be concerned about transmission, but also if they themselves are better off, they're worried and thinking if the spaces are limited, then they would prefer to have people who need their kids to be there so that they can work, you know, that they would go. Everybody's quite concerned about the lack of socialization that kids have experienced. They haven't been with other children. They've been in their own homes, often dealing with parents who are also trying to work from home at the same time. So there's been a real tension about, and also the potential for, you know, domestic violence at home and child abuse. So there's a real concern about this. How do you get this balance right? How can you get kids to go back to school? We are not opening our junior highs and our high schools. Kids that can theoretically learn at a distance are going to be learning at a distance. Universities in general are not opening in September, so all of the professors are going to more web-based teaching. So we're trying to find ways to reduce the harm, as Peter was saying, but address some of the social concerns we have as well about children.
Thank you. Dr. Reddy, I was wondering if you have anything on that front, and maybe taking that one step forward. The timing for this thing seems to me an important sort of touch point. So how do you decide when a lockdown can be relieved? And have we been guilty of doing that too soon, too late, at the wrong time? What has been the experience in India?
Well, it's difficult to second guess the decisions which are taken in a period of great uncertainty. And when the lockdown was announced, it was considered, that was towards the end of March. The scenario globally was of a huge number of deaths being shown on TV screens and news media in Europe and North America. And the scare was that there would be a similar problem in India as well. And therefore, the lockdown was announced at that time. But there was, even during the lockdown and preceding the lockdown as well, there was also a considered decision taken to fly in a number of Indians who were actually stranded outside, whether they were working or studying. They had to be brought back to India, and that continued both before the lockdown and throughout the lockdown and post-lockdown in large numbers. And that's a risk that had to be taken because the Indian citizens had to be also given the safety of return home. But in terms of within India, I think the decisions are now being taken at local level, depending on the local situation. As I said, large parts of India have not been very much touched by the virus, and there a number of economic and social activities have been taken up again, though schooling and college still has not resumed. But in areas which are relatively hot in terms of high viral activity, the local containment is continuing, and there are many restrictions placed on gatherings and opening up of malls and other restaurants and so on. But there is an attempt now to look at schools and colleges opening up somewhere in September. Till that time, the whole scenario would be watched. But this is going to be also decided at the provincial level rather than at the national level.
Thank you. So, Dr. Lee, one of the things that I think Korea has stood out is just your amazing response on the sort of test and contact trace. Is that unique to Korea? I mean, what are some of the lessons that you think could be shared with other countries in terms of replicating? Was it a very useful thing to do in retrospect? Did it make a big difference to the outcome in Korea?
Actually, yeah, because we can see just compared to the MERS outbreak in 2015, actually, we didn't have this kind of system at the time, like the rapid testing and early and contact tracing, early detection, and compared to those situations, when we currently we have that kind of system right now, and not only the KCDC but also the local governments and the local level as well, because we have about like 250 public health centers across the nation, and then they were also trained for this, and this kind of system made difference in this COVID-19 response. But the problem is actually it's the sustainability, because if the numbers, if we can just contain this or suppress the number of the confirmed cases, it's okay. But if the numbers of these cases exceed the control of our capacity, then we also have to think about different kinds of measures to take. That was the one that we were really concerned about within our government during this COVID-19 outbreak response. Actually, what we would like to share is that the rapid preparedness is not that easy, but if the whole government just gather, and then if this multi-ministerial approach acts really fast, then it accelerates this response to establish this response system as well. And also the public compliance and then community engagement comes from the risk communication. Actually, our government, just from the very beginning of our response, we've had this daily briefing by our director, the very highest level officer. So people were really we've developed some kind of trust with the people, and also the public actually followed the recommendations and the guidelines for responding to this COVID-19. Currently, we've had a little increase in the numbers after this converting to this daily life social distancing, but there is no high peak during this phase. We think it's a combination of these this public compliance as well as government effort. And also, just previously, we've talked about this school setting and then school response. In Korea, we have opened all the schools currently, but the schools just enforce the combination of online and offline classes currently, and also it's depending on the school policy. So each school can have what kind of method they use for this online and offline combination classes, and then we've gave very, very strict IPC rules, and then like prevention measures and guidelines. And then the Ministry of Education and KCDC have worked really closely. Actually, the Minister of Education and KCDC Director, we have the meeting every week, and then just evaluate how we've done to protect our children at the school. And then fortunately, we didn't have just a big any kind of a transmission or clusters within the school till now. These kinds of efforts are very, very important, I think, and then that's one of the lessons that we've learned from the COVID-19 response. Thank you.
Thanks very much, Erica. So, Kate, I think it might be a moment just for you to briefly tell us about the good participatory practice guidelines, because I think this, Peter's touched on the need to be sensitive to culture, etc. Do you want to just, because not all the listeners may have heard that document even exists, and maybe that'll point them in the right direction.
It was inspired actually by the experience that we had with HIV prevention trials, and the fact that when there's very poor engagement of community and involvement of community in study design and conduct and implementation and analysis of the results and so on, that you can end up with major problems, as we saw when the original PrEP trials were closed in 2004. So that led to good participatory practice guidelines for HIV prevention trials. But when we came to looking at what was going on with Ebola, we realized you couldn't just take those principles and practices and try to make them work in an emergency setting. There were a number of things you had to really consider. And I guess perhaps the most important one is that when you're conducting clinical trials or research in an emergency setting, you have to make sure that you're contributing to the national response and not pulling away from it, not drawing away the best people to work on your clinical trials. So you have to be working very closely and be part of that national response organization. So WHO thought it would be a good idea to come up with these guidelines, and subsequently there has been a checklist. It's part of the blueprint. So if you go on the WHO website, if you just put in GPP/EP, you'll be able to get through to them and have a look at them and think about how to make them apply in the settings we're in now.
Yeah, and of course we've got the big trials coming. There are some treatment trials already underway, but the big vaccine trials are coming in. But I think, you know, as you already allude, there are principles there that can be applied even in the general response to COVID. So on that note, Dr. Reddy, I have a question here on the Twitter feed that's saying, and I was struck by you saying that the biggest slum in the world, Dharavi, has come out of this relatively unscathed. So what, can you just expand a little bit? What was it that was implemented there, or what were the circumstances? Because, you know, I live in South Africa. This is our biggest fear, and this is where our hotspots are. Our very crowded peri-urban townships have been hard hit. So tell us a little bit more about that.
I think because of the huge fear that this could become a boiling cauldron of COVID-19, with a large number of cases being thrown up because of the lack of physical distancing, as well as even difficulty in maintaining good personal hygiene because of limited access to regular water. A lot of precautions were taken by the municipal authorities in order to send teams for household surveillance. Regular teams were visiting for symptom-based as well as actual testing of temperature and oximetry. You know, with pulse oximetry, almost every person was being tested in the slums on a daily basis. And elderly people who are at very high risk were also moved to other locations out of the slum in order to protect them. Importantly, I think the local community also recognized that there is a threat, and they cooperated fully with all the checks, with the masks, and also with the hand hygiene to the extent possible, and recognizing that even the absence of physical distancing as prescribed could still be countered by other measures. I think there was absolute cooperation between the public health authorities and the local community, and that partnership secured the victory.
Thank you. And I think a great lesson there, perhaps preparedness, as you say, was the major sort of ingredient. Peter, I'm going to turn to you because you've alluded to the fact that, you know, we need to worry about the sequelae of the pandemic in terms of those who are left with chronic disorders. They're obviously social sequelae as well that we're going to have to work our way out of. And I think a number of first world countries, including your own, perhaps could look again. I think Kate's been introspective about Canada's need to look at how they've managed. I know Sweden said the same, how we've looked after our elderly in chronic care homes, etc. So just a little more perhaps forward looking. What are some of the things we now need to do as we move out of hopefully this acute stage into the more long term of taking care of those who've been left either economically or physically in a worse off position?
This is really an essential question for the long term, and maybe at least two reflections on that. One is to create, how to say, safe spaces, and when I think of at the moment in the UK, for example, where are the infections? It's still in the care homes, elderly. It's in hospital settings, and then specific communities. Sometimes we have a lockdown nearly in Leicester, for example, but it's in poor communities, people who live in social housing and so on. So frankly, it's the same story all over the world. But the first thing I would say is we need to rethink in many societies, maybe not in all, but how we deal with the elderly. It's also the official, narrative of this epidemic has been, I would say, close to eugenics. I mean, in the sense that you say, oh, most people are asymptomatic or you get the flu. And then there is what, 1% die, but you know, they're over 70, I'm 71, so over 70, or they have underlying diseases, as if we are not fully part of society. And I mean, I know it's not intentional, but the whole narrative has been going along these lines. That's one of the reasons I came out also, because there's a lot in between. Plus, you know, it's really probably one of the biggest scandals in Western society, how we deal with the elderly, because the traditional family structures have gone. And then we're parking people in pre-mortuary type of institutions. So that is something that maybe it's not so much about the long-term perspective, but if this is a wake-up call, if we don't act on that, I mean, then I think we just should all be ashamed of ourselves. But so creating safe spaces, and the same thing is true for the health system. But then I think the longer term has more to do with the, you know, one thing was the education system. I think young people at the moment, you know, because of increasing poverty, because the schools are not going to function, and that goes from primary schools to, you know, higher education and so on. So how we deal with that, because that could leave a scar for the rest of their lives and a handicap. So that's, and I don't have a solution for that at the moment, but we need to start addressing that. And then, I mean, the massive unemployment that is going to result, again, how are we going to deal with that? At the moment, many states are spending massive amounts of money, increasing the debt in a huge way. Okay, and I think that's absolutely necessary, but how sustainable is that going to be? So I think it's an example also of if we stay within, all of us come from the public health background, or a health background, there's no way we can handle this and have a long-term view if we stay within our public health framework. That's, you know, because the biggest issues are going to be outside. The public health part is, I was going to say is the easy part. It's not easy, but it's more straightforward than all the rest, because, you know, all the things that, you know, we heard from our speakers, I mean, that's a matter of doing it and all that. But the rest, there are many uncertainties, and I don't see the debate. Where is that debate happening? And I understand that also, because we're all racing, you know, against this epidemic. There's such an acute need. But also when you look at Europe, it's an interesting experiment, because every country has a bit of a different response. It's like the states or the provinces, you know, in big countries. And, you know, with Germany doing very well, but now also, you know, it reveals that, for example, the whole, you know, meat packing and slaughter industry is a problem. It's to become vegetarian. You know, I'm not one, but I'm married to one. But I mean, it's really, again, we need to make sure that we are picking up the signals that are coming, and that we do something about that. So, and that will benefit society as a whole. And I agree with the Sunat about the, let's say, the ecological disaster combined with the climate change. So, but it can be very overwhelming, but let's use this also as an opportunity, you know, to fix the care for the elderly, for example, to do something about the, you know, the unbridled exploitation of wildlife, and so on and so on. So that is going to be, but from the health perspective, I think we are not over it, because these chronic conditions, chronic sequelae, are going to add to the burden on health systems that are already under extreme, you know, pressure. So yeah, that's where
Thank you. Thanks, Peter. I'm going to give the last 2 minutes to thank you for that to the three panelists. I'm going to ask you just in the most succinct way to just give your last reflection after, I think, an extraordinary moment of discussion, but not before I say we haven't mentioned some of the essential services, particularly healthcare workers around the world. And I just want to give them a huge warm shout out for work well done under very difficult circumstances. Those who've lost their lives, our very warmest condolences to families as well. But over to you, Dr. Lee, for a last kind of reflection.
Thank you. Actually, throughout this session, I could just review what we have done till now, and then what we should do for the next. Our government is also just concerned very much about how we prepare to the next wave, and then it's more. We've just mentioned the sustainability very much. And then that's the one that we really want to just keep. The sustainability of our normal healthcare system as well as our response system. And then how we can just balance the responding to the COVID-19 and also with this industrial business and or other the social activities, and how we balance all these the problems and issues from the COVID-19 to other public health issues and social issues. So our government will also continue to work on this, and then we would like to have some hear from some better lessons from the other countries as well. So this is a global pandemic, and then I think we have to work together. Thank you.
Thank you. Dr. Hankins.
Two quick things. One is, I think we haven't really focused enough on the intergenerational burden here. We talked about what's happened with the elderly, but the young people have not been working. They're going to face a huge debt load through increased taxes. We need to think through some of that debt that's been building up, and we need to look as well at the environmental crisis the generation is leaving them. It's all mixed up with that. The promise thing that I can say is that although we don't know a lot about immunity, and we have 30 years of science on immunity that HIV has brought to us, we still don't have a single case confirmed of reinfection. And that has some promise. And I think I hold on to that as being a positive.
Thanks, Kate. Dr. Reddy, a last thought from you.
In the early stages of the pandemic, we saw global scrambling and competition in a fairly ruthless manner for personal protection equipment and other resource testing kits and so on. We are likely to see the same thing happen for the vaccine as well as effective drugs. I think we must remind ourselves that we need a global solidarity more than any other time. And the global public health should draw impetus not only from a sense of shared vulnerability, but also from a sense of shared values.
Thank you very much, Dr. Reddy. And I know Dr. Piot is also passionate about that and is playing a role in making sure that we do remember this is a global pandemic. We are a global community. And this is the time more than ever before that solidarity, sharing of lessons and sharing of resources and innovation is going to be absolutely key. And I think generations to come will hold us accountable for how we act in the next few months ahead of us. So I want to now give a resounding thank you to all of our speakers, Dr. Lee, Dr. Hankins, Dr. Reddy, and of course, Dr. Piot, for brilliant time discussion. This hour and a half, I think, is really topped off a fantastic conference. I want to thank our sponsors, Merck Sharp Dome and Gilead Sciences, who've helped us put this COVID-19 conference together. I want to give a shout out to Erica and the Educational Fund. You put a brilliant conference together at the IAS. Thank you for that. And right now, I just want to say thank you to all of you for joining us, and keep safe, protect yourselves, keep your distance, but hug those you can, and make connections where you can. Thank you to everyone.
Thank you.